All right, welcome to this session. In this session, we'll be looking at antihypertensive agents, and we'll walk through this textbook. This textbook is from Katzung Pharmacology. Okay, so we'll walk through it, we'll read through it, and explain the main concept behind it. Okay, now let's start with an introduction. Now, hypertension is the most common cardiovascular disease. There are various cardiovascular diseases. We have arrhythmias, we have ischemic heart disease, uh, we have heart failure. Okay. Now, among all these ones, the most common is hypertension. Now, there was a study that was done by the National Health and Nutritional Survey that was around 2011 and 2012. Now, this study discovered that about 29% of American adults are hypertensive, and 65% of adults that are above 65 years are also what hypertensive. Now, the study discovered also that 60% of both male and female, when they got to 80 years, will also turn out to be hypertensive also, meaning they will develop hypertension once they get to 80 years. 60 to 80% of both male and female. Okay, so now the main reason why we are scared of hypertension is because of its effect on the blood vessels. So hypertension tends to damage your blood vessels, and it damages the blood vessel in the kidney, in the heart, and in the brain. So these three areas are the main areas where hypertension actually damages your blood vessels. So it damages the blood vessel in the kidney, damage the blood vessel in the heart, damage blood vessels in the brain. Now, if the blood vessel in the kidney is damaged, of course, you will expect renal failure. If the blood vessel in the heart is damaged, you will expect coronary heart disease, heart stroke, heart failure rather. If the one in the brain is damaged, you will expect stroke, you will expect dementia. Okay, so these are the complications. These are the reasons why we are scared of hypertension, because it subtly damages your blood vessels. Okay, in the kidney, in the heart, and in the brain. Now, in this same study that was done, it was discovered that majority of those American patients were not faithful to their medication, despite knowing all this idea that it damages the heart, damages the kidney, damages the brain. They were not faithful to their medication. So about half of them were not faithful to their medication. So you can see that it's a major challenge. Okay. Now, moving further, now we'll talk about how to diagnose hypertension. Now, hypertension is not, we usually do not wait for symptoms to appear, because immediately symptoms start appearing, it means that it has damaged the heart, it has damaged the kidney, it has damaged the brain, at least to a large extent. Okay, so we don't wait for symptoms to appear. The best way to diagnose hypertension is by repeated measurement of blood pressure. Keep on measuring the blood pressure. That is how you diagnose hypertension. So there is a table here where Katzung textbook now classify blood pressure. Based on the blood pressure, we now have different categories of hypertension. Okay, so the normal blood pressure is 120/80, meaning 120 systolic, 80 diastolic, while pre-hypertensive are now seen as between 120 to 139 for the systolic and 80 to 89 for the diastolic. We term them as pre-hypertensive. While hypertension starts from 180/90. So whenever your blood pressure is between 180/90, that is where hypertension starts from. Then stage 1 hypertension is between 140 to 159 for the systolic, and 90 to 99 for the diastolic. Then stage 2 is whenever it's greater than 160, we call it what? Stage 2. Okay, so you need to take note of this. However, recent data have shown that hypertension actually starts from 130/80. Yeah, 130/80. That is the new guideline by the American Heart Association. Okay, now you need to take note that with every increase in blood pressure, with every increase of this unit, 20/10, 20 for the systolic and 10 for the diastolic, it doubles the risk. The risk doubles for the damage to the blood vessels in the heart, in the brain, and in the kidney. Okay, the risk of those scarring of the blood vessels increases. Okay, so that's one thing you should take note of. With every increase in this unit, the risk what doubles. Now, what do you think is the okay epidemiological wise? It is discovered that majority of the hypertensive patients or majority of the patients that have hypertension are actually African Americans. Okay, that's one thing you should take note of. And again, between premenopausal women and men of the same age, premenopausal women have lesser risk. They have lesser risk to develop hypertension compared to men of the same age. The reason is because they have estrogen, and estrogen tends to like lower LDL levels. Okay, LDL usually cause atherosclerosis and scarring of blood vessels. So when the LDL levels is lowered, the risk for hypertension will be reduced. Okay, so that is the reason why premenopausal women of the same age as the men have lesser risk of developing hypertension. Now, other risk factors for hypertension include smoking, metabolic syndrome, obesity, dyslipidemia, and even diabetes. Okay, so that is for that. So again, take note that we don't wait for symptoms. It does not usually come with symptoms. Rather, we diagnose it by repeated measurement of what of blood pressure. Okay, so take note of that. Now, what do you think is the etiology of hypertension? What do you think is the etiology? What do you think is the cause? By etiology, we mean cause. What do you think is the cause of hypertension? Okay, for the cause of hypertension, it is divided into two. We have essential or primary hypertension, and we also have what secondary hypertension. So take note of that: essential or primary hypertension and secondary hypertension. Now, the most common one is your primary hypertension, which is that one takes about 90% of the time. Okay, 90% of patients have primary hypertension, meaning we don't know the cause of it. While the remaining about 10 to 15% has secondary hypertension. Now, secondary hypertension is secondary to a cause, so we know the cause of secondary hypertension. Okay, so that's why as a doctor, it's important for you to classify your patient. Is this primary hypertension or is this secondary hypertension? Although majority of the time the patient will likely be primary hypertension, but it's still good that you try to rule out the secondary causes. Now, what are the secondary causes of hypertension? We have renal artery stenosis or renal artery constriction. We have coarctation of the aorta, pheochromocytoma, Cushing's disease, and primary aldosteronism. All these ones are all secondary causes of hypertension. For example, when there is renal artery stenosis, the kidney will sense that there is reduced blood getting to it, and from there the renin-angiotensin pathway will be activated. And once it's activated, the end goal of it is to increase blood volume and by the reabsorption of sodium. And once you have more blood volume, it means that your your feedback loop, that is your blood getting to the heart, will be increased. Okay, so there's a term for it. I think the preload, the preload will be increased. Okay, so that is the idea behind it. The blood returning back to the heart will be increased because now you have more fluid in circulation. And again, coarctation of the aorta is still the same concept behind it, because the blood getting to the kidney will also be reduced. Pheochromocytoma is a condition whereby you have excess of catecholamines, excess of epinephrine and norepinephrine in circulation. That too can lead to hypertension. Okay, Cushing's syndrome or Cushing's disease, you have excess of cortisol. You also have excess of aldosterone. All those ones can predispose you to hypertension, because cortisol can also act as aldosterone sometimes. Okay, so same principle goes with primary aldosteronism. Okay, they will all lead to hypertension. They are all cause of secondary hypertension, and they account for just 10 to 15% of the cases. Okay, however, in majority, that is why in most cases we have primary hypertension, and this primary hypertension is majorly due to increase in the resistance. So it's due to increase in resistance to blood flow, meaning it is the total peripheral resistance that is increased. So the blood vessels are narrowed. That is what usually causes it, because later on when we get to the management of the physiology behind hypertension, we'll notice this formula, that is blood pressure is equals to cardiac output times peripheral vascular resistance. of these two, the primary thing that we discover in essential hypertension is peripheral vascular resistance. That is the main thing we discovered in those patients, not necessarily the cardiac output, but peripheral vascular resistance. Okay, so that is one thing you should take note of. Now, having said that, let's now come to the physiology of blood pressure regulation. How is blood pressure regulated on a normal day? But before we go into that, this blood pressure I've been talking about, what does it actually mean? Actually, it is the pressure in the artery when you use your sphic, okay, to measure. Okay, so the pressure you measure in the artery, that is what we call blood pressure. It's not, we don't measure blood pressure in veins. You measure them in what? In the artery, your brachial artery and the rest. Okay, so that's where you measure blood pressure. So the pressure you measure there is your blood, is the pressure exerted by the blood on the wall of the vessels. So that's what it means. And it could either be systolic or diastolic. Systolic means the pressure exerted by the blood on the vessel when the heart is in systole, when the heart is contracting. While diastolic blood pressure is the pressure exerted on the wall of the vessel when the heart is in diastole. Okay, that is that's what blood pressure means. Now this blood pressure is represented by this equation. You need to know this equation, that blood pressure BP is equals to cardiac output times peripheral vascular resistance. Okay, so it's very, very important you familiarize yourself with this equation. Blood pressure is equals to cardiac output times peripheral vascular resistance. Now, anything that makes cardiac output to be increased, your blood pressure will be increased. Anything that makes total peripheral resistance to be increased, again your blood pressure will be increased. Okay, so that is one thing you should take note of, because this total peripheral resistance is even more, plays a major role than the cardiac output. Is the main key player in hypertension. Okay, because any small change in the radius of the vessel, the resistance will increase by the fourth power. Okay, so it will increase by times 4. So that is very, very important for you to take note of that. Now, in the management of blood pressure, in the regulation of blood pressure, it is regulated by two main systems at 4 anatomical sites. Okay, that is one thing you should take note of. Two main systems at 4 anatomical sites. The number one anatomical site is arterioles. You have also your post-capillary veins, which are capacitance vessels, the heart, and the kidney. Okay, so you can see them in this diagram. We have the resistance vessel, we have the capacitance veins, we have the pumping heart, and we have the kidney. So these are the 4 anatomical sites where blood pressure is being regulated by two systems: the CNS, or the sympathetic nerves, and the renin-angiotensin system, as you can see them here. Okay, these are the two systems that regulate blood pressure at these 4 anatomical sites. Now, this sympathetic system is majorly involved in the regulation of blood pressure for a short period of time, for immediate regulation of blood pressure. Okay, while your renin-angiotensin pathway, that one regulates blood pressure over a long period of time. Okay, that one is the later one that will come in after the sympathetic nerves. Now, having known this, let's just throw a little light on it. For example, okay, let's go now to the first one, which is this baroreceptor mechanism. The baroreceptor mechanism is same thing as the sympathetic control. Okay, the sympathetic control. Now, whenever there is a change in pressure, let's say for example you experience a drop in blood pressure. Whenever there is a drop in blood pressure, the baroreceptor reflex will be activated, and the net goal of it is to increase sympathetic outflow. That's what it means, to increase sympathetic outflow. Okay, if you have more sympathetic discharge, sympathetic nervous system will release epinephrine and norepinephrine. Your epinephrine and norepinephrine will stimulate we bind to this arteriole. You can see the arteriole here. Then we bind to the arteriole and cause constriction of the arterioles. Okay, the arterioles will be constricted, and when the arterioles is constricted, your peripheral resistance will be increased. I get my point. And if it is increased, your blood pressure will go up. Okay, so that is the idea behind it. That is when there is a fall in blood pressure. Okay, because this example given here says that once they give an example of postural change in position. Let's say somebody that was recently reclining suddenly stood upright. When you were lying down before and you suddenly stood upright, your blood will drop down such that your carotid sinus will sense that, oh, there is low pressure, and from there it will activate your baroreceptor mechanism. From there will be activation of the sympathetic nervous system, because initially the sympathetic nervous system are kept inhibited. They were kept inhibited by the stress on the baroreceptor. Now, when you have less volume due to the fall of the blood to the lower limbs, it will kick it will kickstart the sympathetic nervous system. That inhibition will be lost. So there will be loss of the initial inhibition. Okay, then the sympathetic nervous system will be activated. And once it is activated, again it will act at this four sites. It will act at this four sites. You can see it here. It's acting at the arterial. You can see the arrow here. It's acting at the arterial, causing constriction of the arterial, and that will lead to what? Increase in total peripheral resistances. And also it's acting at this capacitance venous here. And whenever it acts on this venous, the blood, the venous return, that is the word, the venous return will be increased. Okay, the venous return will be increased. Meaning the amount of blood getting back to the heart will be increased when it acts on the capacitance venous. Then again, it can also act on the heart itself. When it acts on the heart, it will increase the cardiac output. And when it increases venous return, the net effect of increasing the venous return is to increase the cardiac output. Okay, and whenever cardiac output increase, blood pressure will also increase. Then also it will act on the heart and increase the cardiac output also. Then lastly, it can also act on the kidney on the long run and activate the renin-angiotensin pathway, which also will increase blood volume and then increase venous return and then increase cardiac output. So you can see that the whole goal of this sympathetic nerve, the whole goal of this immediate response is to increase the blood pressure. Then also we also have the renal response to a decrease in blood pressure. So when the amount of blood getting to the kidney is reduced, when there's the reduction in renal perfusion, the kidney will readjust in such a way that it will start secreting renin. And once renin is secreted, it will kickstart the RAS pathway. It will kickstart the RAS pathway. Once renin is secreted, it will kickstart the RAS pathway, so that it's going to convert angiotensinogen to angiotensin 1, which will subsequently be converted to angiotensin 2 by the enzyme in the lung. That is your ACE enzyme. That is for your RAS pathway. Okay. Then angiotensin 2 can now act on the arteries. You can see it here. Let's assume this angiotensin 2. You can see it is acting on this artery. You can see it, right? It will cause constriction of the artery, and also aldosterone will also be formed, because angiotensin 2 can also stimulate the adrenal gland, that is the adrenal cortex, to produce aldosterone. Aldosterone, once it's produced, will cause the reabsorption of sodium and water, which will now again increase the blood volume. From there, once your blood volume is increased, your venous return will be increased, your cardiac output will also be increased. By so doing, you will increase the blood pressure. So in summary, we get to know that there are two main ways by which we regulate the blood pressure. One is by the neuronal mechanism. So we can say neuronal mechanism, and number two is by hormonal mechanism. So hormonal mechanism here stands for your long-term control. Okay, hormonal mechanism is your long-term control. Take note of that. And please don't forget the 4 anatomical sites. In the next video now, we are going to continue with the pharmacology of antihypertensive agents. In this video, we just talked about hypertension. We talked about the epidemiology. It's more common in Black Americans. We talked about the how to regulate blood pressure. Okay, talk about that is normal regulation of blood pressure. Talk about the etiology of blood pressure, of hypertension, primary and secondary. I make you understand that primary is more common 90% of the time. Secondary is just around 10%. Okay, so in the next video we'll continue from here in Katzung pharmacology textbook. Thank you.